is discussing with regard to this concept of the patient experience of care. There was an assumption, I think, in the original triple aim thinking. It was really about service orientation, that consumers would demand interaction with the healthcare system and would want the healthcare system to track, to predict, and to remember. I think, as we discussed in our article as well as in other parts of this conference, that is an assumption that we might need to work around and work with for this population, and understands that at face value that is an important goal, but it may not be as straightforward as Mr. York was suggesting, that people might not want to be tracked and remembered all the time for every interaction that they've had. And so we need to figure out, do some more thinking about how to achieve the experience of care that this population would consider to be value-added, appropriate, and helpful for them. So thanks. I'll turn it over to Kavita.
All right, thank you. And I wanted to thank Cochs for first getting me involved with, I think, this audience. I think it's now been about 2 years. I came to one of the Cochs conferences here in this room. I think it was either last year or 2 years ago, but after we had passed the Affordable Care Act, but before kind of the enrollment and some of what we've seen over the last several months. And so it's been interesting to think about how much has happened in that time. And I was kind of asked to speak a little bit to kind of the mental health parity, substance use, as well as kind of managed care. And given the title of our panel, Integrating Services in Managed Care, I'll focus a little bit on kind of managed care, Medicaid, knowing that you're going to hear from a managed care Medicaid expert in a minute, but I'll take it on a little bit of a national scale. So some things that are interesting about what we've known from the last, I wasn't here this morning, so I know we covered some of the issues around the Affordable Care Act, but the enrollment that's kind of happened and the success that the president announced in the Rose Garden just a couple of days ago is only a piece of this, because not only are we expected to kind of figure out what didn't go very well and how to make it better, but we are projected by 2020 to have enrollment in Medicaid actually start to dwarf the number of persons enrolled in Medicare. So when you think about the kind of underpinnings of Medicaid, and especially for justice-involved populations, and the majority of those persons enrolled in Medicaid plans, there is a huge opportunity, yet at the same time, because of the fragmented nature around how Medicaid is delivered, in the sense that we've got this federal-state partnership. So, you know, unlike Medicare, where you have a Medicare card for Part A and Part B, and you kind of know what that means across the country, or you think you should know what that means, Medicaid plans don't all look the same, and certainly managed care Medicaid plans don't all look the same. And the overarching, I'm going to kind of speak, since I know there's a really heterogeneous audience here, something that those of us who study kind of the financing of health care have been looking closely at, is that there's been an assumption by many governors and many state officials that managed care Medicaid is ultimately cheapest, and you see states moving kind of 100% wholesale into managed care Medicaid plans. The evidence has been to this date mixed in terms of whether, you know, managed care Medicaid means that you can achieve even that cost part of the triple aim, and even more mixed when